start now? So from our last clinical session, there are some parts which are still remaining. We will do them, don't worry. Like I'll just need around 20 minutes. So I'll come whenever I find time at the end of any of your lectures. If I see a gap, and if I'm free at that time, so I'll come right at the end of any session, and then we'll do those 20 minutes. But if you want to revise it, like you have the slides, you can read them and revise them. And suppose if you want to understand it, I think you have access from last year's lectures as well, recorded lectures. So you can listen to them. It's the same content, especially for JVP and the clinical skills. Only that session is named as Clinical Lecture 4, CL4. This time it's CL3 because I had only 2 sessions, so it's CL3. Last time it was CL4 where I discussed JVP and other respiratory sounds and cardiac murmurs. So you can listen to that as well as I'll hopefully do this week. I'll try to cover them. Okay. And it's better because I also wanted you to do to go over some of the content of the cardiovascular system so that like you're familiar with few things before we discuss because there were so many new names on the very first day, so I thought it would be better if we do it later. Okay? Is my voice clear or do I need to remove this? Is it better this way?
Yes.
So can I keep it like this?
Ali.
Okay, so today's session is like 2 lectures. So supposed to be 2 hours, and there are lots of drugs in it, but most of them you have already done in POD, so hopefully it should not be difficult. So let's start. Anti-hypertensive drugs 1 and 2. So our objective is to first to define, because we are talking about drugs to treat hypertension. So first we try to define what is blood pressure and what is hypertension, and then we will revise the physiology of blood pressure regulation so that we can identify the potential targets of pharmacotherapy. And once we know those potential targets, then we will try to describe the principles of pharmacotherapy for the management of hypertension, and then we will try to classify and discuss different antihypertensive drugs, their categories based on their mechanism of action, and then we will discuss the pharmacological properties of those drugs. Okay. And most of these slides, do we have any other mic which I can like? It's difficult to. Okay. So most of these slides are taken from Dr. Dilip's lecture on the same topic last year with this kind of permission. So I just updated those slides. Okay. So what is blood pressure?
It is the pressure that is exerted on the endothelium and the arterial wall. It is the pressure that is created by the blood flowing, and it is exerted on the arterial wall.
Yes, very good. So it's the pressure or the force exerted by the blood flow on the vessel walls or in the circulatory system. So this is blood pressure. So what would be hypertension?
Increase in that.
Yeah, so if that pressure is consistently elevated than the normal, then we call that hypertension. Okay. So what would be, in your idea, what is normal blood pressure and what is hypertension? Like, there is systolic blood pressure, there is diastolic blood pressure. I won't go into the difference, like what are those two. Hopefully you know that and you will do the details in clinical lecture. But do you know what is the normal blood pressure?
120.
120 or 80? Are you sure?
Yes.
All of you are sure that's 120 by 80? So suppose if I say somebody's a blood pressure of 120 by 80, is it normal?
Yes.
Everybody agrees with that? Any disagreements? So suppose if I say like my blood pressure is 120/80. Yeah, like practically it is okay normal, but like based on definitions like this. So if you look at the cutoffs, it has to be less than 120 and less than 80 to be a normal blood pressure. So the moment it becomes 120 and 80, yes, practically we always say normal is 120 by 80. And yes, it doesn't make much difference. But in those definitions, and we have two definitions, one is based on the JNC 8 and the same is followed by the Europe as well. But in US, they have proposed a more stricter version of the definition. The AHA is American Heart Association and the American College of Cardiology. So you see normal is less than 120 and less than 80. But here we have pre-hypertension, here they call it elevated blood pressure. Now here see the range is 120 to 139 and 80 to 89. But they are saying that 120 to 129 and less than 80. So based on this one, if the moment it crosses like 130 in systolic or 80 in diastolic, it becomes a stage 1 hypertension. That's quite strict. Previous classifications and the European classification, they say the moment it becomes 140 or 90, then it becomes a stage 1 hypertension. And then you have a stage 2 and then there's a hypertensive crisis. So we have, and probably the clinician will go in further detail. I don't know, did you get the clinician's lecture on hypertension? But is there a lecture in schedule?
This week.
So you will learn more about these cutoffs, and I don't know which one is used here in Saudi Arabia. Most likely probably maybe the European one, because this is the older version, like, and it's still ongoing in Europe, but and even in the newer recommendations from the Europe, they are still following this. But in 2017, the US came up with this thing. Okay, so just to make you aware. Okay, one more question. Suppose let's keep these definitions in mind, and if somebody comes in with a blood pressure of 145 by 85. So is it pre-hypertension or stage 1 hypertension? Stage 1. So the rule that you follow is, yeah, so you use the higher category. So whether based on systolic, diastolic, whichever is the higher category, you use that to label the patient. So again, these measurements are based on the clinical blood pressure, like the measurements done in the clinics. But if you do an ambulatory measurement over 24 hours, then the average will be different. If you do a nighttime ambulatory measurement, nighttime blood pressures are lower. So then again, the levels will be different. If you are doing the home monitoring, then levels tend to be different. Clinics, they are different. So these cutoffs are different depending where you are. So these are based on the clinical measurement. But here you have clinic measurements, home-based blood pressure monitoring, daytime ambulatory blood pressure monitoring, nighttime ambulatory blood pressure monitoring, and 24-hour blood pressure monitoring. Just to tell you that depending on the situation, these cutoffs can be different. Here again, this American one, like in the clinic, anything more than 130 and 80 is they mean stage 1. They are not talking about pre-hypertension or elevated hypertension. They are talking about stage 1. So anything more than more than or equal to 130 by 80 is stage 1 or hypertension. And the European Society of Cardiology and European Society of Hypertension, they say any time more than or equal to 140 by 90 is hypertension based on clinical measurements. So this was about your definition of hypertension. Now let's come back to the physiology part. So what determines blood pressure? Cardiac output and peripheral vascular resistance. So Blood pressure is the product of cardiac output and peripheral vascular resistance, the total peripheral resistance, TPR or PVR, whatever you call it. So total peripheral resistance. And this is the product. So it's directly related to cardiac output and total peripheral resistance. So either one of them is increased, the blood pressure will go up. If they are decreased, then the blood pressure will go down. So now the cardiac output is dependent on
Heart rate.
And stroke volume.
and stroke volume. Very good. So heart rate and stroke volume, and the heart rate is dependent on. Sorry, stroke volume is dependent on.
Blood ejected per
Venous
So blood ejected is like with each beat is the stroke volume. That depends on what? Sorry? Contractility, very good, and venous return. So how much blood comes in the heart during diastole? So it depends on how much blood is there in the venous system. So venous return or overall blood volume. If there is less blood volume, less blood will come to the heart through the venous circulation. So venous return will be low. They also call it preload. And that comes in the heart, in the ventricle, right ventricle, during diastole. So at the end of diastole, how much blood volume is there in the ventricle and diastolic volume? So this is one. So that will depend on the venous return as well as filling of the ventricles. So that's end diastolic volume or preload or venous return. All these things mean the same thing. And then the other thing is contractility of the myocardium. So suppose if someone has adequate volume and if suppose there is 60 ml of blood in the ventricle at the end of diastole. Now it depends how effectively the myocardium can contract. If it is working fine, it might be able to eject 40 ml out of 60 ml. So ejection fraction will be 67%. That's the stroke volume, 40 ml with each beat. But if the myocardium is not working well, then it will eject only, say for example, 20 ml out of 60 ml. So then the ejection fraction is 33%. And the stroke volume is only 20 ml. Just hypothetical example. So contractility also determines how much blood is ejected and how much volume it has before ejection. So suppose if it had only 40 ml, so even with 50% ejection fraction, it will be able to eject only 20 ml. So it needs to have adequate volume as well as good contractility to have good stroke volume. And then that's per beat. And then how many times the heart beats, that's the heart rate per minute. So that determines the cardiac output. Okay? And then cardiac output and peripheral vascular resistance, which is the peripheral vascular resistance is determined by
The arterioles.
Yeah.
The
Yeah.
diameter.
so the arterioles they can contract muscular arteries and so they can increase the resistance. So by reducing the diameter of the vessel wall by contraction, so you know the resistance increases if the diameter of the vessel goes down. So they can contract and increase the resistance. Similarly, if you want to decrease the resistance, you can dilate the vessel. Okay. So you have these four elements which determine the blood pressure, and these are the four areas where we can use different drugs to reduce the blood pressure. So if you want to reduce the blood pressure, you can either vasodilate and reduce the peripheral resistance, or you can reduce the heart rate, or you can reduce the contractility of the myocardium, or you can reduce the venous return and intravascular volume of the blood. Okay? So how would you reduce the venous volume or the intravascular volume? Sorry? Diuretics. So now based on this information, now the strategies that we have to reduce blood pressure are to reduce the cardiac output, and that we can reduce by reducing the heart rate or its contractility, and that we can achieve with beta adrenergic blockers or calcium channel blockers. Okay. Okay, so either we can use beta adrenergic blockers or calcium channel blockers, because when I look towards the board, so I become away from this mic and then the voice probably is not okay. So this is one strategy. So we have, and you have done the beta blockers and alpha blockers and POD. So it will be sort of a revision for you. Okay. The other possibility is we dilate the resistance vessels, thereby we reduce the peripheral resistance and we reduce the blood pressure. And we can use again calcium channel blockers, renin-angiotensin system blockers, alpha 1 adrenoceptor blockers and vasodilators. All these will reduce the peripheral vascular resistance or total peripheral resistance, and thereby they will reduce the blood pressure. Now you see calcium channel blockers are in both categories. So again, these are a little bit different types of calcium channel blockers. So there we have subclasses. So some of them are more effective in reducing the cardiac output, the others are more effective in reducing the peripheral resistance. We will talk about them. And then other thing is we can reduce the vascular volume by using diuretics. Okay. So these could be our strategies. Now then, based on the mode of action of these drugs, we can classify them into diuretics or sympatholytic drugs, which will be most of your autonomic pharmacology in POD. So we have centrally acting sympatholytic means why we are using sympatholytic, because I did not go into that physiology part, like when we speak of blood pressure regulation. So then what are the mediators which can increase or decrease the blood pressure? So that would tell you the role of sympathetic system, which can increase the heart rate, which can increase the contractility, which can increase the peripheral vascular resistance. So all these things can be mediated by a sympathetic nervous system. So anything which brings down the sympathetic nervous system, which decreases the sympathetic nervous system outflow, its effects will reduce the blood pressure. So that's why we say sympatholytic. So we have centrally acting sympatholytic drugs like methyl-dopa, we have alpha blockers, we have beta blockers, we have mixed blockers which act on both alpha and beta receptors. So these are sympatholytic drugs, and then we have ACE inhibitors like captopril, lisinopril, enalapril. Again, these drugs, ACE inhibitors, they end in pril. So then remember them by this pril, okay? Captopril, lisinopril, enalapril. And then we have similar but slightly different angiotensin 2 receptor antagonists or blockers. This, in short, they are called ARBs, angiotensin receptor blockers, ARBs. They block the angiotensin 2 receptors, okay? And they are sartans, losartan, candesartan, valsartan, so all sartan. So these are ARBs. And then we have renin inhibitor, which is currently we have only one, aliskiren. And then we have calcium channel blockers. One class has the names ending in dipines, nifedipine, amlodipine, things like that. And then we have another subclass where we have diltiazem and verapamil. And then we have direct vasodilators, which include minoxidil, hydrolazine, nitroprusside, and similar drugs. Okay? Are you following this? Are you following the sleep? So diuretics. Do you remember anything about diuretics?
They can block the calcium channels in the lubricant.
You want to block calcium channel?
They decrease
Sodium
Hmm? Sodium channel. So suppose if you want to cause diuresis, am I loud enough? Can you hear me? Okay. So suppose if you want to cause diuresis means you want to increase the volume of urine. So that you reduce the water or fluid present in the body, mainly the intravascular compartment. Initially it will come from intravascular compartment, then the extracellular compartment as well. So, how would you cause diuresis? What would be the most important mechanism? There are many mechanisms.
Osmolarity.
Yeah, so if you increase the sodium loss in the urine, water will follow. I say it's a relationship like it between a lady and a man. Wherever the lady goes, man will follow. So wherever the sodium goes, water will follow. So you increase the sodium loss, water will follow. That will lead to diuresis. This is one like the mechanism that we will be talking today. There are a couple of other mechanisms as well. There will be. Did you get any diuretic lecture in your first renal block?
Yes.
There was a diuretic. Yeah, because previously we used to have. I don't know these days, but like they used to be. So you're familiar with diuretics. So now, if you want to reduce sodium, like you want to increase the loss of the sodium in the urine. So that means like, how would you do that?
Stop reabsorption.
Block the sodium channel.
Yeah, but where? So, so sodium is filtered in the glomerular filtrate. Okay, there's not. Then it gets reabsorbed. So you want to block its reabsorption. Okay. So where does the reabsorption take place in the nephron? Where? So proximal convoluted tubule, loop of Fenley, and distal convoluted tubule. Loop of Fenley, especially the thick ascending limb, TAL, thick ascending limb. So how much sodium is lost in the proximal, reabsorbed in the proximal convoluted tubule?
6%, 80%.
Yeah. So you can see around how much? 60%. Yeah, 60% sodium is reabsorbed in the proximal convoluted tubule. Around 25% is reabsorbed in the thick ascending loop, and around 10% is reabsorbed in the proximal, the early part of the distal convoluted tubule, and around 5% here in the collecting ducts, where the fine tuning is taking place. But for the sorry, you can't hear me? Okay. Those girls at the back say they can hear me. Okay. Because I find it much interactive if I'm moving around and talking to you while this one. Okay. So, but we won't block sodium reabsorption here at proximal tubule. Okay. The drugs that we use will act mainly at, like, we will be concerned for our today's talk at these 2 points, where thick ascending limb of the loop of Henle and the distal convoluted tubule. So do you know which transporter is there in the loop of Henle? Sodium potassium 2 chloride in the thick ascending limb. Okay. And in the distal convoluted tubule? Sodium chloride co-transporter. Okay. So in the sodium chloride co-transporter is inhibited by thiazide diuretics, and the sodium 2 chloride potassium co-transporter in the thick ascending limb is inhibited by the loop diuretics, because so as the name says loop, so these are like they are working on the loop of Henle. Okay. There are other diuretics as well, like spironolactone, and so working on the aldosterone in this area. But we will just talk about these two today, and probably you have another 2-hour diuretic lecture in your renal block in 3rd year or in semester 6. So you will do the details of all diuretics at that time. We'll just talk about these two. So thiazide diuretics, the examples are chlorothiazide, hydrochlorothiazide, chlorthalidone, indapamide, but probably you need to, like this hydrochlorothiazide, The chlorothiazide and hydrochlorothiazide is similar, and so this is the prototype, and then you have chlorothalidone, which is also important. And these are the most very widely used drugs, not most, but like quite widely used drugs. I'm talking about the hypertension. Okay. And they decrease blood pressure by, they cause the sodium loss, which leads to water loss, so that decreases the intravascular volume, that decreases the venous return, that reduces the preload, that reduces the stroke volume, and that reduces the cardiac output, and that reduces the blood pressure. But thiazide diuretics has another mode of action as well. It has a direct vasorelaxant effect as well, which other diuretics don't have. Thiazide diuretics have a direct it's not that prominent, like the major effect is through diuresis, but they have an additional effect, vasorelaxant effect, which is only typical for thiazide diuretics. Other diuretics don't have this effect. Okay, so they have dual mechanism, and that is the reason that when it comes to the treatment of hypertension, for the chronic treatment, in diuretics we usually choose thiazide diuretic compared to loop diuretics. Loop diuretics cause a lot of diuresis, so they are used more in acute situations. Some patient may be put on chronic and loop diuretics, but usually they are used in acute situations when there's too much edema and this pulmonary edema, you want to get rid of a lot of fluid immediately, so you can use loop diuretics. But for the treatment of hypertension, generally we prefer thiazide diuretic if we have to choose a diuretic. Okay, it will come like there are so many drugs. Then the question is like which one you use, and usually your exam questions will be based on that. You will get a scenario and either we will ask we can ask mode of action as well, but and side effects. But usually the way we ask, which of the following drug is contraindicated in this patient, or which of the following drug is the best choice to treat this patient's hypertension. So, and that answer will be based on the patient's comorbidities and the side effects of the drugs. So again, now in third year, most of your questions will be based on clinical scenarios. So get you until semester 4, you had more direct questions. Now there will be more clinical type of questions. So mode of action we just discussed. So we have sodium chloride co-transporter in the distal convoluted tubule. That's where it works. So what happens? Normally this co-transporter transports from the lumen of the distal convoluted tubule. Transports sodium chloride into the epithelial cell, and then from here through the sodium potassium ATPase, sodium goes into the interstitial space, and the chloride goes into the interstitial space through its own transporter. Thiazide diuretics block this sodium chloride co-transporter, and that way they increase the luminal concentration of the sodium, and water will follow, and that will lead to diuresis. Adverse effects: hyponatremia, obviously because it's leading to sodium loss, so there will be hyponatremia. But then there's hypokalemia as well. Why?
Because sodium is in exchange for potassium. So
Yes.
when sodium
Where?
is going one way, potassium is coming the other way.
Where?
Uh,
Which part of the nephron?
Collecting duct and the
I'm not sure.
the collecting duct.
It should be collecting duct because we are doing this in the distal convoluted tubule, so it has to be distal to that, huh? So probably collecting duct. So what happens? So in the lumen now you have more sodium, okay? And in the filtrate or the urine which is present in the distal convoluted tubule, you have more sodium now because it's blockage. Now when this thing reaches the distal part of the distal convoluted tubule and the collecting ducts, over there the cells sense more than normal sodium, so they want to reabsorb it. So aldosterone will start working, and what will aldosterone do? Sodium reabsorption at the cost of potassium. So whatever extra sodium that we decided to lose, some of it gets reabsorbed in those collecting ducts under the action of aldosterone at the cost of potassium. So the potassium loss happens over there, and that's why there is hypokalemia. Why there is hyperglycemia? These are adverse.
Because if aldosterone production is increased, the what's it called? It's because of ACTH increase. So the HP.
No, aldosterone is not increased because of ACTH. ACTH is not the stimulation for aldosterone.
Oh, okay, never mind.
Insulin production needs potassium.
Yes, insulin production
Needs potassium.
needs potassium. Who is saying that? You? Yes, so there's a role of potassium in the release of insulin. But what is the role? You did endocrine block, I think, sometime recently? Last year?
First block of last year.
Yeah, last year, so it was just a year ago. So how insulin is released? Any idea?
Stimulation of hyperglycemia.
Can you be a little bit louder?
By stimulation of hyperglycemia.
Okay, so then what happens? What is the role of calcium and potassium over there? You're right,
The
hyperglycemia.
release from the vesicles.
Sorry?
The release of insulin from the
Yeah, it
vesicles.
releases from the vesicles, but how? What happens? Like, what is the role of calcium over there, and what is the role of potassium over there? The vesicular release happens under the effect of girls. The release of insulin happens under the effect of calcium. So when the calcium concentration goes up intracellularly, then the insulin will be released. Now the calcium concentration will go up when the calcium will come from outside through voltage dependent calcium channels. Now it will come in when the membrane is relatively depolarized. And that happens when there's another potassium channel present on those beta cells, which is ATP dependent, ATP sensitive potassium channel, which when it gets inactivated or deactivated, then the flow of potassium from inside to outside stops and the membrane depolarizes, and then the calcium goes in and insulin is released. So when the system has hypokalemia, so that leads to relatively hyperpolarization of the membrane and less release of the insulin from the beta cells. So because of hypokalemia, there is less release of insulin, and that causes hyperglycemia. Okay?
Doctor,
Yes.
can you repeat it?
Yes. The hypokalemia decreases the insulin release, which is dependent on voltage dependent calcium channels, which are activated by the inactivation of ATP dependent potassium channels. I'll show you an image in the end. Probably I've kept it for my reference. So I'll try to explain it on that one. So that's one mechanism. So that happens when there's hyperglycemia. So when there's high glucose inside, that inactivates those potassium channels, and then there's depolarization and calcium goes in and insulin gets released. But in hypokalemia, there is hyperpolarization in that area because of potassium. So then the calcium doesn't go in, so those channels are not activated, so calcium doesn't go in, so insulin. So if you remember, because of hypokalemia, there is decreased insulin release, and that leads to hyperglycemia. Okay? Can you remember that?
Yeah.
Okay. So that leads to hyperglycemia. So now see, if someone has diabetes, would you want to use thiazide diuretic in them? Because it will increase their glucose level further. So then it will not be your first choice if someone is diabetic. So that's how you decide in comorbidities. You can use them if needed. Like someone, the blood pressure is not being controlled. When one drug doesn't control, you add another drug, then you add another drug. So probably you might add at some point in time, but this will not be your first choice. Okay? It increases LDL. Why? the same insulin mechanism. So if it reduces insulin, so it will affect the lipid metabolism and lead to increased LDL. It causes hypercalcemia. Why?
Maybe because there is no depolarization of calcium.
55 minutes ago. Huh? Sorry?
Maybe because there is no depolarization, so calcium will not come inside the cells. It will stay outside the cells.
No, it's nothing to do with depolarization. It's just the electrical gradient in the renal cells. It's causing hyperglycemia, but because it's increasing the calcium reabsorption. Why? Can you guess?
So that's a
So what happens
Oh, the potassium.
now when you block this thiazide diuretic, sodium is not coming in. So this epithelial cell has low sodium. Okay, than the usual.
To compensate.
Yeah, so now we need sodium. So now where can it get? So there's another exchanger, sodium calcium exchanger here on the basolateral side. So that gets activated because there is low sodium in the cell. So that exchanger will bring in the sodium, but it will take out the calcium. So calcium will be reabsorbed from the cell into the interstitial space. To compensate that, the calcium will get reabsorbed from the lumen. Okay? So that we can get sodium from the interstitial space into the cell. Okay? So overall net effect would be the calcium will be reabsorbed from lumen to the interstitium. Because of this, there's another exchanger over here, sodium calcium exchanger. So it's not a co-transporter, it's an antiporter. Okay? So that leads to hypercalcemia. So it can have like there's an adverse effect, but at the same time, if there's a tolerable hypercalcemia, like relatively higher calcium levels, that can be beneficial in elderly people, especially postmenopausal women.
Doctor, I have a question. I'm not sure, but can we say that because we have hyperglycemia, that means that we have low insulin, and the reduction in insulin will reduce the LDL receptor production in the liver. Because of that, we have increase in LDL.
Increase in LDL. Yes, so LDL, yes, because it's affecting the overall I don't remember the enzyme, but it's affecting the lipid metabolism, so that will increase the LDL. Right now we are talking about the calcium.
Yeah.
Okay.
I know.
And then there's hyperuricemia as well. And why?
because it's destruction of proteins.
Sorry?
So there is destruction of the proteins.
Can you say it louder?
Destruction of some cells.
No. There's no destruction of cells. It's again about the secretion, excretion, reabsorption of things in the kidney.
Increase the production of urea.
Absorbing urea.
Yeah, so what happens? Uric acid again, it's secreted, like there is a secretory mechanism for organic acids in the proximal tubule. Okay? I won't go into those details. So that secretory organic acid secretory apparatus or system, that's saturable. That's and this uric acid is secret. It's not like filtered. It's also some things are filtered, some things are secreted, and then they are reabsorbed. So uric acid secreted. The thiazide and loop diuretics are also acids, so they compete with them. So they affect the reabsorption as well as secretion. So net effect is the overall there's less uric acid is lost in the urine, more is retained. So it reduces the secretion and increases the reabsorption. So in the end, we end up with more uric acid level in the body. And can you name a disorder which can happen with elevated uric acid levels? Gout. So someone who has already gout. So someone who has gout and now you diagnose him with hypertension, would you start them on thiazide diuretic
No.
or loop diuretic? Both of them cause hyperuricemia. Both of them cause hypokalemia. These things, except hypercalcemia, loop diuretics they cause hypocalcemia. Thiazide diuretics cause hypercalcemia. Loops cause hypocalcemia. Okay. Otherwise, other side effects are similar. Okay. So similar. So that's how we tend to ask questions. So, a person who has gout, now you diagnose him with hypertension. Which of the following drug is relatively contraindicated? And then, again, not absolutely, but relatively contraindicated. So these drugs are very cheap, so that's the advantage, and they are suitable for patients with from African descent, and also in the elderly population they are useful. The patients from African descent, they don't respond well to the ACE inhibitors or ARBs. So then we tend to go with the thiazide diuretics in them, and also elderly thiazide diuretics. And because of this calcium reabsorption, in the long term, it reduces the risk of hip fractures in older patients. Disadvantages: it can cause hypokalemia, it can cause or precipitate gout, and it can cause impaired glucose tolerance. Loop diuretics, again we discussed their mode of action. So you have furosemide. So in US they call it furosemide, and in UK they call it furosemide. So just the spelling difference. The same drug. And then there's bumetanide, and you have torsemide, and then you have I think it's not written here, ethactinic acid. You might have heard it. So these drugs have sulfur moiety. So if you want to use someone has sulfur allergy, then you can switch them to ethactinic acid. It's a loop diuretic. I forgot to mention it over here. So how do they work? We just discussed that they will work on the sodium to chloride potassium cotransporter in the thick ascending limb of the loop of Henle. Okay, so you have this cotransporter which transports sodium from the lumen to the interstitial space, and loop diuretics will inhibit this one. So you have similar. So again, as I said in the beginning, they cause profound diuresis, and that's why we use them in acute situations, and so it can lead to profound extracellular fluid depletion, hypokalemia, same side effect, hyperuricemia. Also, the same cotransporter is present in the inner ear. So again, the use of these drugs chronically can lead to ototoxicity, and also it can worsen the ototoxicity if it is being used with some other ototoxic drugs like aminoglycoside and things like that. And it can also lead to hyperglycemia, same mechanism, because of hypokalemia. Now let's talk about sympatholytics. So centrally acting sympatholytic agents. The thiazide diuretic and loop diuretics, you want to avoid them. So relatively contraindicated, not absolutely contraindicated, but relatively contraindicated. You want to avoid them because it will precipitate their gout, because they cause hyperuricemia. So sympatholytics. So do you remember the adrenergic receptors, which are alpha and beta? And how many types of alpha? Alpha 1 and alpha 2. How many types of beta? Beta 1, beta 2, beta 3. Okay? But we'll talk about beta 1 and 2. So alpha 1 and 2. So where is alpha 1 located and what's its role? Sorry? Blood vessels, huh? And what does it do? Yeah, so it causes the contraction of the vascular smooth muscle cells, so leading to vasoconstriction, increasing the peripheral resistance. So that's alpha 1. So if you block that, it will lead to vasodilation. So you need a blocker to cause the vasodilation to decrease the resistance. Huh? What about alpha 2? Sorry, presynaptic. What is their role? Anybody from the back? Those two ladies talking to each other, discussing alpha receptors. So what is the role of alpha 2 receptors? Any idea?
To inhibit the release of the
Yeah, so they are autoreceptors. So it's more of a negative feedback loop. So they reduce the release of the same hormone. So the norepinephrine, epinephrine are released from the presynaptic nerve terminals, and on the same nerve terminals, alpha 2 receptors are present, which are stimulated by that, and they in turn inhibit the release of further norepinephrine, epinephrine. So if you stimulate alpha 2 receptors, it will reduce the release of epinephrine. So it's more of like, so it will reduce the sympathetic outflow. So it's a sympatholytic. It's the agonist, but it's a sympatholytic. Okay. So if you use any agonist of 2, it will overall reduce the sympathetic output, and that will lead to all those effects. It will reduce the peripheral vascular resistance, and it also will reduce the cardiac output. So in the centrally acting, we have methyl dopa, we have clonidine, similar mode of actions. We don't use them commonly. Methyl dopa is used only in hypertensive disorders of pregnancy. And what are hypertensive disorders of pregnancy?
Preeclampsia and eclampsia.
Good, preeclampsia, eclampsia, and before that, just gestational hypertension, pregnancy-induced hypertension. And then we have preeclampsia, eclampsia, there's HELP syndrome, and it can lead to hypertensive crisis, but eclampsia is severe enough. So we use in that. So there are different disorders. Like there's a spectrum of disorders, and methyl dopa is one of the drugs which can be used in that situation because it doesn't affect the fetus. And why wouldn't it affect the fetus?
Because it doesn't cross the placental barrier.
Okay.
Can you say that again, please?
I asked why doesn't it affect the fetus, and your friend said it doesn't cross the placenta. That's what you said. So this is just we talked about. So you have presynaptic neuron, which releases epinephrine, norepinephrine, and you have alpha 2 receptors, which are autoreceptors, these red ones. And if you use an agonist, so it will inhibit the release of epinephrine, norepinephrine, so it will reduce the effect on alpha 1 and beta receptors. Okay, and the postsynaptic effector cells. Okay, so this is the methyl dopa mode of action. Adverse effects are many. We won't go into much details, and because of these adverse effects, we don't use it commonly only in pregnancy disorders or pregnant hypertensive disorders of the pregnancy. And so now let's talk about alpha adrenoceptor antagonists or blockers. So now you're blocking the alpha receptor. So which one would you like to block? Alpha 1 or alpha 2? Alpha 1, because they are present on the vessels which cause vasoconstriction. So if you block alpha 1, it will lead to vasodilation and will reduce the peripheral vascular resistance. So again, we have two categories. We have non-selective alpha blockers, phentolamine and phenoxybenzamine. Again, they are not commonly used. There's a very limited indications. I'll just mention one of them. And the commonly used for hypertension among alpha blockers. Otherwise, again, alpha blockers are not your first choice for hypertension. But if you have to use for hypertension, usually we use alpha 1 selective agents which work on the vascular alpha 1 receptors, like prazosin, doxazosin, terazosin, and uradipil and indoramine. Like if you remember this zosin, that I think that should be sufficient. Like prazosin, doxazosin, that type of thing. Now, do you where else are these alpha 1 receptors present? Any idea?
Prostate.
Sorry?
Prostate. Prostate.
Prostate, very good. And something before that? Urinary bladder. Neck of urinary bladder. So it can help. So it can relax smooth muscle cells present in the urinary bladder sphincter at the neck and the prostate as well. So it can help in the benign prostatic hyperplasia, any urinary outflow tract obstruction, including especially in benign prostatic hyperplasia. So someone who has benign prostatic hyperplasia and hypertension, probably you might choose this one. Again, may not be the first line, but like yes, it will be helpful. So when it comes to non-selective alpha blockers, they cause profound postural hypotension and reflex tachycardia, and that's why we don't use them much. Only this phenoxybenzamine has one role. It is distinctive in blocking the, like it irreversibly alkylates these receptors, so irreversibly blocks these receptors. This is the only drug which is blocking them, these receptors irreversibly. And we want to do that only when, do you know what is pheochromocytoma? What is it? Okay, so it releases lots of catecholamines, and so if when you want to do surgery, and obviously during the surgery there is a manipulation of the gland, so there will be excess release of preformed catecholamines. So there's always a danger of hypertensive crisis during the surgery. So you want to cause first the alpha blockade, and in that situation for the surgery preparation you might want to use phenoxybenzamine. You can use phentolamine as well, but like for the surgery preparation you want to use phenoxybenzamine. So that's one indication. Otherwise, commonly when it comes to hypertension, we usually go with the alpha-1 selective blockers like prazosin and other selective alpha-1 blockers. They can reduce the blood pressure. Also, alpha blockers reduce LDL and increase HDL, and that can be useful someone who has dyslipidemia as well. And they can also reduce the symptoms of blood outflow tract that we just discussed, and that's why it can be useful in patients with BPH who don't want to do surgery. So patients who have BPH and don't want to do surgery, obviously they need a drug therapy, and you will have one lecture on the pharmacotherapy in BPH in renal block. Okay, so one of the agents or one category of the agents is alpha-1 blockers. So if they have hypertension as well, and they have BPH, they have dyslipidemia, so then probably this drug can be helpful. Okay, but again we have to see, is it enough to reduce the blood pressure? Otherwise we might want to add, but this can be helpful. Okay. Adverse effects, again these alpha-1 blockers also cause hypotension, postural hypotension, especially during the first few doses. First 2-3 doses, they can cause hypotension. But later on it becomes alright. Also alpha-1 blockage, because it causes vasodilation, so it will cause, even in the nose as well, it causes this nasal congestion, like you are having the flu. Similar mechanism. And that's why in flu, to decongestants are usually the sympathomimetics and pruritus. Now let's talk about beta blockers. So we have beta 1, 2, 3, but we'll talk about beta 1. So where is beta 1 located? Heart, huh? And what is its role? So increasing contractility, which is called inotropic effect. Okay, anything positive inotropic means increasing the contractility. Decreasing contractility is negative inotropic. So beta 1 stimulation will increase the contractility, like positive inotropic effect. It will increase the heart rate, like AC node firing. So it will. That is, what is that effect called? Chronotropic, yes. So that's positive chronotropic effect, increasing the heart rate by increasing the firing rate of SM node. It will also increase the conduction velocity at the AV node, which is called, search for it. I don't know, it's, I think dromotropic or something like that. So it will increase the conduction velocity at the AV node. Okay. That's the role of beta 1 receptors in the heart. And if you block those, obviously the contractility will go down. So cardiac output, stroke volume will go down, cardiac output will go down, heart rate will go down, again cardiac output will go down. So these effects, the negative inotropic and negative chronotropic effects will reduce the cardiac output and blood pressure. Okay. Where's beta 2? Lungs, bronchial tree, huh? What does it cause over there? Bronchial dilation. So if you block that, what will happen?
Bronchospasm.
Bronchoconstriction. So do you want to use that in asthmatic patients? No, because they need bronchodilation. They are using beta agonist. So if you give beta blockers, like obviously this asthma will become worse. So, but we might have a selective beta 1 blockers. They probably may be used. So these beta blockers compete with catecholamine for beta adrenergic receptors. By the way, besides lung bronchioles, where else we have beta 2 receptors? Okay, uterus. Where else?
Arteries that supply the skeletal muscle.
Yes, arteries supplying the skeletal muscles. So if you, so we need more blood flow to the muscle during the sympathetic output. So, see, just imagine the sympathetic, like they call it fight or flight. So during fight or flight, you need more cardiac output, so heart rate should go up, the contractility should go up, cardiac output should go up. You want to increase the blood pressure and heart rate, so you want to increase the peripheral vascular resistance as well. So alpha 1 blockade. But you want more blood to the muscles because you are running or fighting. So you have beta 2 on skeletal muscles in the vessels supplying skeletal muscles, which lead to vasodilation. Over there, beta 2 stimulation will lead to vasodilation of those arteries. So again, you need more blood to those muscles. You need to see well during that situation, so you have vestibular dilatation. You don't want to go to washroom, so all those parasympathetic urges are suppressed during that time. So just remember those things by this way. So just imagine you are in a fight or flight mode. Then what do you need? So these beta blockers, they decrease blood pressure by reducing the cardiac output via beta 1 mediated effect. They decrease the renal release from kidney as well. So they have this another effect on peripheral vascular resistance. So one beta 1 effect is on the heart cardiac output, but this through renin they are affecting the peripheral vascular resistance as well. So that's again beta 1 mediated. And there are some drugs which have intrinsic sympathomimetic activity, and that may not reduce the heart rate or cardiac output that much as compared to other beta blockers. So we have non-selective beta blockers which act on both beta 1 and beta 2 receptors, and the example is propranolol. This was the initial prototype drug when we did not have selective drugs. So this has a potential of causing bronchoconstriction. So obviously you don't want to use in patients who have asthma or COPD, especially the elderly patients who have hypertension and cardiac problems. They also have COPD and things like that. So you don't want to use propranolol in them. Propranolol has other indications as well. Do you remember your endocrine block? No? Any other indication? Anything related to thyroid?
I think contraction of the
Pregnancy.
Yeah, but like, do you remember the thyroid problem where you can use propranolol, not pregnancy? Hyperthyroidism, yes, you can use propranolol over there. And also probably in GIT you will learn during the portal hypertension. If someone who has esophageal varices, you can use propranolol. So again, it has some role over there. Now let's talk about cardioselective beta blockers. We call them cardioselective because they block selectively beta 1 receptors. Again, when we speak of the selectivity, it's not absolute. It's relative. So the drug which is beta 1 selective, if you increase the dose, it will block some of the beta 2 receptors as well. So there is cross reactivity. Okay? But so beta 1 blockers we have like atenolol, metoprolol, and ismolol. And then we have another category which have intrinsic sympathomimetic activity. So they have partial agonist activity. And examples are pindolol, oxprenolol. And then we have mixed blockers like alpha 1 adrenergic receptors and beta receptor blockers. So alpha beta blockers both like mixed receptors. It's a mixed blockers, and the example is labetalol, carvedilol. So it blocks both alpha 1 as well as beta receptors, and they are more effective in reducing the blood pressure as well. Adverse effects of beta blockers: bronchospasm. We just discussed. You know why, huh? And bradycardia, because obviously heart block, so it reduces the heart rate, so it can cause bradycardia. It affects the conduction velocity, so it can lead to heart block as well. Would you use it in a diabetic patient? Why not?
When a diabetic patient is hypoglycemic, he feels palpitations. So now if you block these palpitations, he will be in more danger because he's not receiving a warning to go and consume sugar.
Very good. So those diabetic patients who are on hypoglycemic agents, when you treat diabetes, there are drugs which may not cause hypoglycemia. Then there are drugs, including insulin, which cause hypoglycemia, which can cause hypoglycemia. And obviously, when there's hypoglycemia, they immediately need glucose. So these patients carry some sugary stuff with them, like candy or chocolate or anything, which they can eat to increase the glucose level if they are going into hypoglycemia. But how would they know they are going into hypoglycemia? Yeah, because whenever there is hypoglycemia, there is sympathetic outflow. Why there is increased sympathetic outflow? Because this sympathetic nervous system dependent, catecholamine dependent gluconeogenesis and glycogenolysis in the liver. Do you remember that? So to increase the glucose production from the liver, we need more epinephrine, norepinephrine. So there's increased sympathetic output. And because that same sympathetic output will increase the heart rate, which will be felt by the patient as palpitations, tachycardia palpitations. They will have anxiety, they will have sweating, they will have dizziness. So with these symptoms of hypoglycemia, like palpitations, these things, they realize that they are going in hypoglycemia and they need to take something sugary. Otherwise, hypoglycemia can lead to seizures and death as well. So it's more dangerous. And we usually counsel them to make them aware that they are going into that. They should know the symptoms. So if someone is on beta blocker, they will not develop these symptoms. They will not develop tachycardia or palpitations. So they would not know they are in hypoglycemia. Number two, even because the production from the liver, the glucose production from the liver will also be slower because of beta blockade. So their symptoms will be masked and the recovery will be slow. So that's why you don't want to use beta blockers in somebody who's diabetic and is on hypoglycemic agents. Okay? And also this abrupt withdrawal can precipitate ischemic heart disease. How? Any idea?
Is it because of sudden vasoconstriction?
Yeah, but why?
Because of
Other effects?
Take the reflex. See, you remember the tolerance? Yeah, mechanism of tolerance. So if you are giving a blocker of something, the receptors will be upregulated. This is a mechanism. If you are giving an agonist, the receptors will be downregulated. This is a mechanism of tolerance. And the beta blockers and the beta receptors are notorious for that. That their receptors, if you are giving beta blockers, the receptors are upregulated, so that the effect with time decreases and you need to increase the dose to produce the same effect. That's tolerance. This is POD concept, okay? So now someone who's on beta blockers, their beta receptors are upregulated and their catecholamines are also in the system. Now if you abruptly stop beta blockers, they will have sudden sympathetic effect because the receptors are there in a higher quantity. So there will be more stimulation, more contractility, more increased heart rate, so tachycardia, and that will worsen the cardiac ischemia. And obviously the blood pressure will also go up. So that's the mechanism. Yeah. Also, this importance people don't. This is also very important, especially for male patients. So you should be aware of that as well. Okay. Do you want, while sitting here, 2-minute break?